Good afternoon, everyone. My name is Kimberly, and I will be sharing with you a summary of Group 8's literature review, which was on the topic of racial disparities in the healthcare system. The following individuals, Lauren, Carl, Roberto, and Ben, were members of my group, and I will be the one presenting our information today. So, a little breakdown of our presentation today and what we will be discussing. Firstly, I will give a quick overview of the subtopics in our literature review and the information and research that was found and analyzed. I then will discuss the policies that have been implemented and who benefits from these implementations. I will also discuss the effectiveness of these implementations and what needs to be done to address the inequalities present in our healthcare system. Then, finally, I will discuss the need for advancement in racial equity in our healthcare system and share our discussion question for the class. So, to begin, the first subtopic that we discussed for our literature review was the relationship between racism and healthcare. So, numerous researchers and studies have determined that there are several intersecting factors that cause a lack of proper healthcare, poor health, and discrimination for visible minorities. The main determinant is racism, which occurs through interpersonal, systemic, institutional, and cultural variations. This can affect the socioeconomic status of individuals, access to services such as proper grocery stores and pharmacies, and general discrimination based on stereotypes and preconceived derogatory ideals. We found that poverty, low employment and education rates, residential racial segregation, and discrimination all influence the health and healthcare of racialized individuals. Race can affect not only the quality and service of healthcare received, but also the overall health of individuals and their offspring. Racialized individuals who experience this type of discrimination forego preventive services, postpone medical tests and treatment, underutilize health services in general, and report worse patient physician communication and lower care rates compared to their white counterparts. Racism within our healthcare system is not the only factor in disadvantaging targeted groups, but the policies and structures in place impact the health of racialized groups. This can be tracked back to the root cause of institutionalized racism, which is colonization/colonialism. This has shaped policies, laws, politics, economics, and social views, which now disproportionately affect racialized groups by showing a system of a racial hierarchy. The next topic we discussed in our literature review was the impact of COVID-19 on racial minorities. So, as everyone is aware, COVID-19 has had a tremendous effect on the entire world, but has a tremendous effect on especially racial minorities. The rate of COVID-19 infections has been significantly high on ethnic minorities. American statistics have shown that compared to white Americans, Black and Hispanic patients have had higher rates of infection from COVID-19. The impact of segregation and inequality in our society can lead to limited access to healthcare facilities and vulnerability to infectious diseases such as COVID-19. With this being said, racial minorities are more likely to be affected by diseases because of their lack of access to healthcare resources. When it comes to the COVID-19 pandemic, racial minorities in particular have struggled tremendously. American statistics shown that in regards to COVID-19 testing, multiple states have administered drive-through testing. However, African American households are 3 times more likely than white households to be without a car, making these facilities less accessible to African Americans. When we look at a statistic like this, we can see the difficulties African Americans are facing during this pandemic. With limited access to COVID-19 testing, this can result in individuals being unaware that they are infected with the disease, which can result in them actively passing it on to others, which ultimately increases the number of infected citizens. Research done in Toronto has shown that 4 of the top 5 neighborhoods with the highest infection rates are each home to a population of over 60% minorities and where 19% of the population identify as Black. With this, we can recognize that minorities are at a higher risk for this virus and are being impacted severely by this virus. Another subtopic that we evaluated during our literature review was examining what research has been observed regarding intersectionality and its impacts on healthcare disparities. What we found is that there is a consensus among authors that intersectionality certainly plays a role in creating disparate healthcare outcomes for many individuals. In this section, our group identified two recurring themes amongst the sources we examined. The first theme is that while intersectionality is regarded as having an impact on healthcare outcomes, current literature has a tendency to oversimplify the complex relationships that exist between intersections of a person's identity and the quality of healthcare they may receive. For example, one of the authors whose research we observed stated that there is a recognizable tendency for researchers to use the term women and minorities when referring to individuals who are most likely to be underprivileged and experience disparities in Western healthcare systems. The issue with this term being used in the literature is that it implies an exclusivity between gender and racial identities. We know through our learning in this course, when we examined intersectionality in class together, that an individual experiences more than one intersection of their identity at a time. The second theme we observed through our research is that despite what research exists in the area, there remains a policy and literature gap that must be filled to respectively prevent and further examine how macro socio-structural systems of power and oppression create and maintain an environment that allows disparities in healthcare outcomes to exist based on the intersections of an individual's identity. The final topic that we looked at for our literature review was who does our healthcare system ultimately privilege? The research conducted found that the voices that are privileged are the Canadian state, white settler Canadians, and people with access to better resources. The Canadian state makes the rules that we all live by and can manipulate the laws to their own advantage. In this case, the voices of marginalized groups such as Indigenous First Nations, Black Canadians tend to go unheard. Canada has very clearly used law and legislation and documents like the Indian Act to carefully create a complex system that places reservations in the care of the federal government while placing health and healthcare within the domain of the provinces. When situations arise for children in need on reserves, the federal government and the provincial government fight over which branch is obligated to pay for medical treatment. In Canada, low-income individuals and families are more likely to live in conditions that will negatively impact their overall mental and physical health. With this in mind, we would think that the Canadian state, understanding the socio-economic factors as well as the intersectionality of race, gender, and class, would go out of their way to identify the areas where people are slipping through the cracks, but unfortunately they do not. Now discussing the policies and practices that have been implemented, we have found that the Canadian government has failed to implement policies to protect its racial minorities from infections and lacks the engagement to provide these individuals with adequate healthcare resources. For example, research conducted has shown that during the H1N1 pandemic, the province's Black population was 10 times more likely to be infected. With this, the Ontario government was aware that pandemics affect specific racial groups differently. Knowing that the H1N1 pandemic affected Black individuals quite tremendously, no policies or plans to protect these individuals from the COVID-19 pandemic was implemented. With no implementations of policies to protect individuals, this has led to an increase in positive COVID-19 cases for ethnic minorities. This has ultimately shown that the Canadian government has not been effective in providing specific policies to prevent ethnic minorities from severe illnesses that can severely impact their health. Our group has decided that in order to address the inequalities in our healthcare system, more research needs to be done to understand or acknowledge that race intersects with gender and other intersections to create further disparities in healthcare. It must be understood that our healthcare system oppresses the voices and experiences of women, African Americans, the Indigenous community, and other minorities who face unequal healthcare services resulting from the intersections they experience between race, gender, and class, among many other identities. Additional policies and practices must be implemented to ensure individuals who are racial minorities have access to better and adequate health services. And it is very important to see and diminish the socioeconomic status relationship in our healthcare system. Individuals who identify as a minority and may have lower income deserve access to adequate health care and health resources to ensure their well-being. Finally, discussing the need for advancement in racial and ethnic equity in our healthcare system. While Canada prides itself on being a multicultural nation, in reality, our citizens do not receive equal treatment. In order for Canada to be perceived as an equal, multicultural nation, the individuals in this country must be able to achieve equal health care to their white counterparts. Denying racial minorities the right to adequate health care does not demonstrate an equal nation. While Canada watches these individuals struggle day to day and their access to healthcare and adequate resources does not get better, it shows the favoritism to white, wealthy Canadians. The question we came up with for our class discussion was, given what you've heard in our presentation and your thoughts beforehand, do you believe universal is an appropriate classification for our healthcare system? Why or why not?